மியூட்ல தானே இருக்கு.
Hello, madam. Hi, ma'am. Hi, all of you. Hi, all of you. Am I audible?
Yes, Dr. Valar, you are audible. Yes.
Yes, ma'am.
Yes, very much.
Okay, ma'am. So we'll start at 2, ma'am. Sharp at 2. And
Yeah, sure.
first case, actually, presenting, we just have Dr. Grace from Dr. Sarah. Grace, are you ready? Dr. Sarah, are you there? May I know who are all ready with the cases? Somebody from Mada Medical College. Who's presenting from Mada Medical College? From Panimalar?
Yes, ma'am, I'm ready.
Your name, ma?
Harshavardhani, ma'am.
Harshavardhani. Panimalar. From Panimalar, huh?
Yes, ma'am.
One case.
Yeah, one case, ma'am.
Yeah, okay. Mada Medical College, they are not ready. I mean, they haven't joined it. Okay, fine. Okay. Anybody else is ready with the case? Surinder? Surinder, are you ready? Surinder?
Madam, yes, madam.
Okay, okay. Suppose if somebody doesn't, I mean, they're not on time, then you can, when I call, you can start presenting.
Yes, madam.
Hospital, Archana will be joining shortly. Archana.
Ma'am, I have joined, ma'am.
Join. Okay, fine. Okay. So it may not
Madam, please,
whoever is, I mean, if
madam, please make me a co-host, madam.
co-host,
Yes.
Yes,
wait. Dr. Sarah, are you ready, Dr. Sarah? Dr. Sarah?
Ma'am, I'm ready, ma'am.
You're ready. Okay, you're ready with
Yes.
2 cases. Okay. Okay, Sarah. Good. Shortly, we'll start in another 3 minutes. Okay?
Yes, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am.
Okay.
Yes, ma'am.
Ma'am, we are also ready. Mada Medical College.
Thank you. Who's that from Mada Medical College? May I know the name, please?
Madam, Dr. Brinda, ma'am.
Dr. Brinda from Mada Medical College. Harshavardhani from Panimala. Okay.
Hi, good afternoon, Valar.
Ma'am, good afternoon, ma'am. Good afternoon,
Yeah,
ma'am.
yeah,
Welcome, ma'am. Nice to meet again after a little longer time.
Yeah. It's wonderful. Yeah.
Yeah, yes, ma'am. That we can get connected from where we are. We'll start at sharp at 2, ma'am.
No problem. Take your own time.
Yes, ma'am. Ma'am, shall we start, ma'am? It's 2.
Yeah. Sure.
Welcome, Chandra, madam. You have come. Welcome, ma'am. All the senior professors, Rajlakshmi, ma'am, Chandra, ma'am. So this is a very good afternoon to you all. So welcoming you all to the 30th City Pathology Meet. So we finished so we're meeting after a little longer time and eager to see you, eager to hear you online. And so with all your continued cooperation and support, we are going on. I think we will touch the 50th. Okay, ma'am, let's start with the first case. This is Dr. Sarah Grace from Vijaya Hospital. She has 2 cases to present. Dr. Sarah, can you share your screen?
Yes, ma'am. I'll share my screen, ma'am.
Yeah.
Ma'am, you're able to visualize the screen, ma'am?
Yeah. You're there.
Yes, ma'am. Shall I start, ma'am?
Yeah, please. Yes, please.
The first case is a 61-year-old male who came with a history of hemoptysis on and off for 1 month. He had a past history of pulmonary tuberculosis. CT scan showed an irregular lesion in the left lung, and they had suspected tuberculosis and to rule out malignancy. A CT-guided biopsy was done. So this was the CT-guided Trucate biopsy. We can make out the core of a very diffuse sheets of almost like lymphocyte-like small cells. No mitosis, no necrosis, mild atypia, and areas like looking like molding probably. And the other sections showed areas where there was extracellular amorphous material in between the cells. These areas showed these cells look more like lymphocytes. So an occasional scattered plasma cells are also seen. So this is a similar picture. You can make out the extracellular deposit with the small lymphocyte-like cells surrounding it. So we had actually initially called it suspicious of malignancies with features of amyloidosis. We gave 2 possibilities. One was a small cell carcinoma and other was lymphoma. And we suggested immunohistochemistry for confirmation. So the IHC was done in a referral laboratory and we found that the cells were positive for CD45, 20, PAX 5, CD79A, and they were negative for PAN-CK and CD56. They were also negative for CD10, 23, and 5. and that was lambda light chain restriction. The proliferation index using Ki67 was 5 to 10%. Congo red was positive for amyloid. So immunohistochemistry and Congo red helped us confirming the diagnosis of a low-grade mild lymphoma of the lung with amyloidosis. So coming to a few words about primary pulmonary extranodal lymphomas. Mild lymphoma is one of the common primary lymphomas of the lung, but it is a rare entity which usually presents in the 6th decade, usually asymptomatic, so generally diagnosed at a later stage. But they have an indolent course and good prognosis. Radiologically, they are difficult to pick up. They can have small nodules in the radiology, or a diffuse pattern, or an interstitial infiltrate, or a peribronchial thickening. Sometimes it can be associated with lymphadenopathy. This patient had both primary pulmonary lymphoma, mild lymphoma, along with amyloidosis. So there are 3 forms of pulmonary amyloidosis. There is a nodular pulmonary amyloidosis, diffuse alveolar septal amyloidosis, and a tracheobronchial amyloidosis. It can be either a localized amyloidosis, or it can be associated with a primary systemic amyloidosis. It can be associated with indolent B lymphoproliferative disorder, like in this case, or it can be associated with connective tissue disorders. So these are the references. I'm at the end of my first case, ma'am. Should I go to the second, ma'am, and have a discussion at the later, combining both of them together?
Yeah, you can finish your second case and then we can have a discussion.
Yes, ma'am. Yes, ma'am. So the case number 2 is a 64-year-old female who had a nodule in her cheek for 10 months. Clinical diagnosis was basal cell carcinoma. So this was a low part scanner view of the section, and we can make out a nice dermal unencapsulated lesion. On higher examination, we were able to make out these papillary areas lined by cells which had a eosinophilic cytoplasm with apical snouts and a basally located small dark staining nuclei. The other areas showed more of a complex tubulo-papillary architecture with focal cribriform areas. So on zooming on the cribriform areas, we found that was a little more nucleomegaly, mild nuclear atypia, and in some cases there were areas showing prominent nucleoli also. So this was our histological diagnosis. It's a ectopic hydroadenoma papilliferum with a low-grade DCIS. So coming to the discussion, we had done an immunohistochemistry for this case. It was done in a referral lab, and it was found to be CK7, ER, GC, DFP.
Dr. Sarah, you can go a little slow,
Oh, yes, ma'am. Yes, ma'am. Yes, ma'am. Yeah. So it was CK7, ER, and GC, DFP, and mammoglobin positive. SMA and P63 highlighted the myopithelial cells. It was intact throughout. There is no breach. So the diagnosis was confirmed. So as we know, hydroadenoma papilliferum initially was thought to be a apocrine gland or an nexal tumor, but now it's more of a modified anogenital mammary-like glands. So the commonest site is an anogenital region. It can arise in the axilla and the periumbilical region. Ectopic sites are very rare. Very few cases have been reported in the head and neck, chest, and abdomen. So this was in the face, the cheek. So it was a very rare site for a hydroadenoma papilliferum. So we call it an ectopic hydroadenoma papilliferum. Rarely, there are case reports where they undergo in situ-like changes analogous to the breast. So we had a low-grade component of the DCIS with the cribriform, mild nucleomegaly, and prominent nuclear at few places. So we gave it as a focal, focal low-grade DCIS along with the hydroadenoma papilliferum. So generally, they are a dermal-based lesion, usually unencapsulated, can have a pseudocapsule. They are histologically very similar to the intraductal papillum of the breast. Complex proliferation of papillae, acini, and tubules, and they're lined by bilayered epithelium. Apocrine differentiation can usually be made out at least focally. And as we discussed, CK7 is positive. They can be positive for both ER, PR, even androgen receptors can be sometimes be positive. CA, EMA is usually positive in the epithelial component. And the mammoglobin and GCDFP are also seen. So that tells that it's probably an anogenital mammary-like gland. So they have a histogenesis from there. And just like the breast, the myoepithelial component will take up P63 and SME. These are my references. We have only 2 cases reported with ductal carcinoma and entity. So in case you have a hydroadenoma-like areas and you see a cribriform area, a little more nucleomegaly. So that is always a possibility of ductal carcinoma in situ or even a frank invasive adenocarcinomas arising in a hydranoma papilliferum. Thank you.
Thank you, Dr. Tara. They were two beautiful cases from you. And any
Thank you, ma'am.
Valer,
Thank you.
சொல்லுங்க ma'am.
this is actually wanted to bring out and document the rarity of hydradenoma papilliferum in the cheek and or the head and neck. Actually, we had a problem of diagnosing this because it is common in the vulval region. And then when we went to the vulva, and then it was given the ectopic site was can occur. So that is why we diagnosed this case. And the first one, as Sarah said, the mammoglobulin, the markers for mal lymphoma was positive. Clinically, histologically, beginning we thought of a small cell carcinoma. And she explained it very well, I think. Thank you, Sarah. You did well. And
Thank you, ma'am. Thank you, ma'am.
anybody want to? I mean,
Madam, and amyloidosis, the special stains, what was done, madam?
Ma'am, actually, we didn't do it, ma'am. It was Congo red done in a referral lab with immunohistochemistry. We were not able to do it here, ma'am.
Oh,
Yes, ma'am. But they
But it
confirmed it's Congo red. Yes, ma'am.
Yeah, both the cases are very nice, madam. And
Thank you,
Dr.
ma'am.
Sarah,
Thank
very
you, ma'am.
nice explanation.
Thank you so much, ma'am.
Very
Thank you,
strange
ma'am.
to see amyloid. It's a rare combination of lymphoma and amyloid.
Yes, ma'am.
Maybe, as you said, it may have incited amyloid. There are many epithelial carcinomas that incite amyloid, but here is a lymphoma which has come along with an amyloid. Yeah.
Yes, ma'am.
and that ectopic hydranoma, DCIS, how often, what is the incidence? Is very rare.
Very rare, ma'am. Actually, there were only 2 case reports so far of hydranoma as such having a DCIS component. Only 2 cases. So ectopic side DCIS has not been described. Actually, the DCIS component kind of confused us. Yes, ma'am. Yes, ma'am.
actually, ours will be the second.
Actually, what was done for the patient? What did they do?
Ma'am, actually, the patient is she's willing to come on a close follow-up. No, it was quite a wide excision. The margins were all 2-3 millimeters away, so not. It wasn't close to the margins, ma'am. 3-4 millimeters. There was a clearance, so she's just on follow-up, ma'am.
Okay.
Yes,
Thank you, Dr. Sarah. Thank you so
Thank you
much.
so much, ma'am. Thank you, ma'am. Thank you, ma'am.
So can we go on to the next case, Dr. Harshavardhani? Are you ready? Dr. Harshavardhani from Panimala.
Yes, ma'am.
Can you share your screen?
Is my screen visible, ma'am?
Yes, your screen is visible. Welcome.
Good afternoon, all. So I'm Dr. Harshavardhani, Assistant Professor from Department of Pathology in Panimal Medical College. And I would like to thank the organizers for providing me this wonderful opportunity. Also, I would like to thank my HOD, Dr. Rajalakshmi, and the reporting team for allowing me to present this case today. So, starting with the case, it's a 77-year-old gentleman who presented with complaints of difficulty in passing urine for the past 3 days. And also he had complaints of lower abdominal pain with distension. On examination, the clinician on per abdomen, there was lower abdominal distension with palpable bladder. And perirectal examination revealed grade 4 prostatomegaly. And laboratory investigations PSA was within normal limits. They have proceeded with radiology, and first, to begin with, transabdominal ultrasonography revealed severe prostatomegaly with bladder outlet obstruction. And then on doing a plain CT abdomen, it showed a large solid mass. So these are the sagittal and the coronal views of the plain CT abdomen, where you can see it was a large solid mass with varied heterogeneous enhancement in it, but still it was well defined and it was limited within the prostate and not involving the adjacent tissues. However, there was only minimal fat stranding, which was just suggesting of inflammation. So radiology was more in favor of a large benign prostatic hyperplasia. So with this on the presentation and all the radiological findings, their clinical impression was benign prostatic hyperplasia. So to treat this symptoms of that benign bladder outlet obstruction, the surgeons proceeded with open prostatectomy. So open prostatectomy is nothing but a simple prostatectomy where they just enucleate the entire prostate. And so hence we will not have a proper well-defined margins to comment upon. So this is the open prostatectomy specimen which we received, where you can see it is just like a large apple. Actually, when we received, we thought it to look like a miniature brain tissue. So this was prostate which measured about 450 grams and measuring around 11 centimeter in greatest dimension, with the external surface as you see is white and nodular. And this is the cut surface where you can see again a somewhat a lobulated architecture with the color ranging from gray tan to yellow. So these yellow were the friable areas suggesting of necrosis. And there were not obvious any areas of hemorrhage identified, and it was firm in consistency. So at this point, we had the gross differentials of, having such a huge lesion of around 450 grams and 11 centimeter in diameter with focal areas of necrosis. We had two differentials in our mind, one being the benign prostatic hyperplasia, and the next being leiomyosarcoma. So here I would like to stress upon an entity called as giant benign prostatic hyperplasia. You may wonder, like, it's not that all benign prostatic hyperplasias will present as like a huge mass. So this giant prostatic hyperplasia is an entity where when we call it as giant BPH only when the size or the volume is more than 500 grams, whereas ours was 450 grams. So our initial gross differentials were these two. So on proceeding with the microscopy, this is the lower power view where you can see it's a mesenchymal, like you are seeing somewhat a pleomorphic cells here and there with spindle cells which are arranged in a vague pattern. And this is the focus where you can see there are areas of necrosis in it. Going to a somewhat higher power, again, you can see the cells which are still to polygonal. And here you are seeing somewhat multinucleated cells which are arranged in a patternless pattern, and interspersed you are finding lots of vessels which are somewhat having a hemangiopericitomatous look. So this is again a higher power to show specifically this vessel where you can see that a morphology which is like antler horn, and in the background again you are seeing those pleomorphic cells which are ranging from the spindle to polygonal and highly pleomorphic cells. Further higher power to show you those multinucleated tumor giant cells as well as the pleomorphic cells, and you don't find any specific pattern in it. Further higher power view where we are seeing the cells which are highly pleomorphic, like multinucleated tumor giant cells which are having prominent nucleoli, and these are the atypical mitotic figures. And there were also areas of necrosis. So with this overall microscopic picture of a highly pleomorphic lesion which doesn't have any particular pattern, and with a wide range of pleomorphism, and mitosis was around 4/10 high power field with 30% areas of necrosis, our microscopic differentials now turned into sarcomatoid carcinoma and high-grade sarcoma. And it is true that we didn't find any glandular component which was either benign or malignant, but still in the back of the mind, we had sarcomatoid carcinoma as a differential. So with this microscopic differentials, we proceeded with immunohistochemistry. So I told you the differentials, one is sarcomatoid carcinoma, and among the high-grade sarcomas, our differentials first, as the common things come common, our first differential was leiomyosarcoma, and then we also found those pleomorphic cells having somewhat a rhabdoid feature. So rhabdomyosarcoma was our next differential. We had solitary fibrous tumor because of those hemangiopericitomatous blood vessels in it. And there were focal lymphoplasmacytic infiltrates which were noted. So we had in the back of the mind inflammatory myofibroblastic tumor, and the last resort GIST, and if not at the last, prostatic stromal sarcoma. So first, to begin with, to prove the antigenicity of the tumor, we did Wyman and it was positive. And at the second level, so we just wanted to first rule out sarcomatoid. So we proceeded with pancytokeratin, where it was negative. So sarcomatoid carcinoma was ruled out, and also microscopically also we didn't find any biphasic architecture. And next we proceeded with SMA, and SMA surprisingly was negative. So we ruled out leiomyosarcoma, and in the next step we did 3 markers. So we did Desmin, myogenin, and CD34. So first coming to Desmin, Desmin showed a beautiful diffuse cytoplasmic positivity. So just being a more sensitive marker for rhabdo, still we wanted to do a specific marker of myogenin to confirm rhabdomyosarcoma, but unfortunately myogenin turned out to be negative, so we ruled out rhabdomyosarcoma. And then we did CD34. CD34 was positive. It had a focal membranous positivity, but still we were not able to come to a conclusion because CD34 can again be positive in prostatic stromal sarcoma, say solitary fibrous tumor, as well as inflammatory myofibroblastic tumor. So then we proceeded with the third step of markers, first being progesterone receptor. So progesterone receptor, it showed focal nuclear positivity. So still we weren't able to rule out anything. And then we proceeded with STAT6 to rule out solitary fibrous tumor, and it turned out to be negative. And then we did CD117 for GIST, and it was again negative, so GIST was ruled out. And then finally we did ALK1 just in case to rule out inflammatory myofibroblastic tumor. And then again, this also turned out to be negative. So finally, with immunohistochemistry, we concluded it as prostatic stromal sarcoma. And these are the pictures, immunohistochemical pictures to show this is the Desmin diffuse cytoplasmic positivity, and CD34 of membranous positivity, and then PR, it had focal nuclear positivity. So with this is a table again to sum up our differentials and the markers which we used. So based on this table, so for in our case, CD34 was positive, SMA was negative, Desmin was diffuse positive, and PR was positive. So with this high pleomorphic sarcoma and the IHC, we concluded this case as high-grade prostatic stromal sarcoma. So coming to the discussion, a brief discussion on this. So this prostatic sarcomas, they comprise actually less than 0.1% of all the primary prostatic neoplasms. And generally they have bimodal age distribution. This specific entity of tumors arising from the prostatic stroma was first described by Gordon and his colleagues in their article in 1988. So mainly it comprises of 2 entities. One is prostatic stromal tumor of uncertain malignant potential, and the one more thing is prostatic stromal sarcoma. So this prostatic stromal sarcoma is again divided into low and high grade. So why is it necessary to divide them into low and high grade is that this low grade tumors are said to have a high rate of local recurrence, but whereas they don't metastasize, whereas when taking into the role a part of high-grade sarcomas, they are said to be more have the metastatic potential even at the time of presentation. So it is very important to distinguish based on the morphology of whether it is low-grade and high-grade. So what are the features based on which they are distinguished is that one is the tumor cellularity, the mitotic count, the cytological atypia, necrotic features, and the stromal overgrowth. So just a brief note on the patterns of, there is, first I told you the entity of prostatic stromal tumor of uncertain malignant potentials. So they have 4 morphological patterns. So one is the hypercellular variant, second is the myxoid one, third is the degenerative atypical pattern, and the fourth being the Phillips-like pattern. And there again comes the confusion whether it is really necessary to know these 4 patterns. But what articles and studies say that if, in whatever the pattern it is, it's potential to turn out into a sarcoma or its potential to regress or everything is going to be the same. So they don't have any prognostic significance in distinguishing the separate histological variants. So prognostic factors of this prostatic stromal sarcoma, like any other tumor, the same thing like tumor histology, tumor grading, tumor size, staging, and surgical marginal status. But what research says, like unlike other tumors, here the size, grading, and histology is of no prognostic value, and only the staging at the time of presentation and the surgical marginal status will play an important role when it comes to prostatic stromal sarcoma. But unfortunately, here our clinician, based on the radiology and the clinical workup, as they were more into the diagnosis of benign prostatic hyperplasia, it was just an open prostatectomy, that enucleation procedure was done, and we were not able to comment exactly on the marginal status. So why this case today in this presentation? So because of its rarity, because only less than 0.1% of primary prostatic neoplasms are being prostatic sarcomas, and the diagnostic dilemma. Diagnostic dilemma not only from our pathologist point of view, but from the very beginning, clinically, its presentation and radiology, it was more in favoring BPH. And again, our IHC markers were also not like the exact pattern what we expected. And also, for such cases, because of its limited data, there is a need to emphasize on the fact that in such patients, long-term surveillance and the need for multi-modality approach is very essential. So these are my references, and thank you.
Doctor, that was a very good presentation.
Thank you,
And
ma'am.
yeah, and I thought I joined a little late, but
Oh.
I felt that the radiology people said it has nothing to do with the prostate, right? What was the radiology image diagnosis? It was not coming from the prostate.
It's a
That's what
prostate
they
is
said,
a
right?
tumor which is limited to prostate, ma'am.
Did they say
A
that?
solid.
No, it was
Yes,
outside the prostate or something you said, no?
No, ma'am. It's a large
Something
solid
within.
mass which is limited to the prostate and not invading the adjacent structures. There was only peripheral fat stranding, which is suggestive of inflammation, ma'am.
Oh, so it was attached to it was in the prostate itself.
Yes, ma'am. It was occupying the entire prostatic tissue, ma'am, not invading any other adjacent structures.
Ma'am, the thing was they thought about a benign prostatic hyperplasia because it was well defined and it was not infiltrating, as Harsha put it.
Very nice case, Harsha. Very nicely presented.
Thank you, ma'am.
Only thing is, as Madam said, there was no radiological clue at all to this lesion, Harsha. I mean, they did not even think of. Was it
Yes.
very bland radiologically? Because sarcoma is usually infiltrative. There maybe have been some
Ma'am, they could have
additions.
picked it
what
up
I was
in MRI maybe, ma'am, but because of the financial constraints, patient was not willing for an MRI. So to relieve the bladder outlet obstruction, they directly proceeded with open prostatectomy, as it was quite large in size.
Yeah, maybe they could have done a frozen to know the nature of the lesion and then proceeded with the more radical dissection. I don't know. What is the protocol they follow in a high-grade sarcoma of the prostate? I don't know.
Ma'am,
Chemotherapy
they
is
were
first,
not
I think.
thinking about a high-grade sarcoma at
They
all.
didn't think
That was
about
the thing they didn't think about.
That's why they didn't want a frozen, right? Okay.
It would
No,
have
the
made
prior
headache for us.
surgery was done, madam. Prior surgery, anything TRP are done.
It
First
was
time,
not done, ma'am.
because post-operative spindle cell lesions
Yeah.
usually DD for the stromal cells in a biopsy specimen, usually
Yeah, there is an
Get any
entity
history suggestive of previous truss or TUR being done, ma'am?
Yes.
Nothing was done.
Yes.
They directly proceeded with open prostatectomy.
Okay. That
Madam, microscopy wise, we thought about a post-operative spindle cell lesion, but then the atypical mitosis and the pleomorphism and everything made us think about a sarcoma.
high grade.
Yes, ma'am.
Okay.
Yeah.
Nice
And
case.
also the fact that
Nice
it had little rhabdoid differentiation. I think Desmond was positive, right? But myelin
Yes,
was
ma'am.
not.
Yes, ma'am.
Yeah. Stromal
Yeah. I
sarcomas.
was also thinking
rhabdoid.
SFT also with the floret-like cells might be sometime present. Could this be one of the cases? I thought.
STAT6 was
SFT stat 6 was
yeah.
negative.
STAT6 was there.
And
You
too much of
proved it, I'm
pleomorphism,
saying
madam.
before that. Yes.
That was a beautiful diagrammatic representation of the IHC markers. You explained it
Absolutely. Yeah.
clearly. That was
Thank
nice,
you, ma'am.
Dr. Harsha. And
Thank you, ma'am.
there was no metastasis. There was no any evidence of any metastasis.
Ma'am, unfortunately we lost follow-up of this patient, ma'am.
Okay.
அது குலுங்காம வண்டி ஓட்டுங்க.
Okay.
Thank you, Harsha, and
Thank you.
congratulations for the nice presentation also. Thank you.
Thank you, ma'am. Thank you.
A lot of disturbance and interruption. I don't know.
Okay, Dr. Harsha.
The Zoom
thank
is
you.
not. Yeah.
Ma'am, it's okay, ma'am. There was a yes. Now it's okay, ma'am. Okay, shall we go on to the next case? This is Dr. Brinda from Madha Medical College. Dr. Brinda?
Yes, ma'am, I'm here.
Please share your screen, Dr. Brinda.
Okay, ma'am. Good afternoon, one and all present here. I am Dr. Brenda, Associate Professor of Pathology from Madha Medical College and Research Institute. I am very much thankful to the opportunity given by Dr. Sushma ma'am, our HOD, and City Pathology Meet organizers. Thank you so much, ma'am. And I'm going with my presentation. This is a case of an 18-year-old female who was admitted with the chief complaints of pain in the right lower abdomen and fever, intermittent hematuria for past 2 days. And she had a loss of appetite and loss of weight. And she had a past history of recurrent hematuria and recurrent urinary tract infection and suspected to have urachal cyst, but the imaging studies were inconclusive at that time. On general examination, she was a thinly built female and poorly nourished, and she was pale, and her vitals were within normal limits. On systemic examination, the abdomen showed abdomen was soft and no organomegaly, and there was a localized tenderness in the right iliac fossa. Other systems were normal, and the clinical diagnosis of acute appendicitis was made. On investigation, complete blood count.
Are you able to see the screen? I'm not able to see the screen.
Ma'am, we are able to see the screen, ma'am.
I don't know why. Suddenly the screen is not there.
Let me check, ma'am. I think we
We
are
are-
all.
We are okay. We are able to see.
We are able to see, ma'am.
Don't know why.
You can continue, Dr. Brinda.
Yes, ma'am. On her complete blood count showed a hemoglobin of 9.8 grams and MCV was 71 femtoliter and mild microcytic hypochromic blood picture. And the total count and differentials were normal. And random blood sugar was 73 milligram per deciliter and renal function tests were within normal limits. Chest X-ray and CT abdomen were normal, and the MRI abdomen showed a 1 centimeter urachal cyst, and the final preoperative diagnosis of acute appendicitis and remnant of urachal cyst was made, and she underwent laparoscopic urachal cyst excision and appendicectomy. We received the specimen of appendix and excised urachal cyst for histopathological examination, and the specimen of appendix, that is attached with mesoappendix, measured 6.5 centimeter in length, and cut section showed an yellowish mass at the tip with circumferential involvement of size 1 into 0.5 centimeter. Other areas of the appendix, the lumen identified and was 0.3 centimeters in diameter. And attached mesoappendix, there were no lymph node identified. On microscopy, the section study showed neoplasm, which is occupying the tip of appendix, composed of cards and trabeculae of atypical cells, separated by an extensive abundant extracellular mucin. And the cells have moderate amount of eosinophilic cytoplasm and round to oval nucleus with salt and pepper chromatin. And there were 3 to 4 mitotic figures for hyperfield were noted. And in areas we saw Paneth cell metaplasia with granular eosinophilic cytoplasm. And towards the periphery, the tumor shows a characteristic nesting pattern, and which is infiltrating into the muscularis propria, and serosa and the mucosal lining was intact. And we did a special stain because of this extracellular mucin pool. The PAS, it was showing positivity in the mucin pool. And we did the IHC, that is chromogranin, because of the salt and pepper chromatin of the nuclear features. We did the IHC chromogranin A, and which was showing diffusely positive. And Ka67 was also showing 3 to 4% positivity. And we thought of differentials like neuroendocrine tumor because of this I had seen diffuse positivity of the chromogranin A, and Problet cell adenocarcinoma because of that extracellular mucin pool and Paneth cell metaplasia or goblet cell adenocarcinoma and low grade appendiceal mucinous neoplasm and mucinous adenocarcinoma as differentials. And these are all the points favoring neuroendocrine tumor, that is intact mucosa and cards, trabeculae, nesting pattern of the tumor cell arrangement, and salt and peppery chromatin in the nucleus, and mitosis 3 to 4 per hyperfield, and diffuse positivity of chromogranin, and Paneth cell metaplasia was also mentioned in neuroendocrine tumors of appendix. And goblet cell carcinoma, as a newly arising term, it is having abundant extracellular mucin and Paneth cell metaplasia and presence of neuroendocrine tumor cells also. But we have an we found intact mucosa and diffuse chromogranin positivity. In this case, actually, neuroendocrine tumor cells are more than what we expected in the goblet cell adenocarcinoma of the appendix. And all other that extracellular mucin pool and low-grade nuclear atypia, which lead at differential for this low-grade appendiceal mucinous neoplasm and the mucinous adenocarcinoma, but the chromogranin ruled out all the differentials. Final impression was made as well-differentiated neuroendocrine tumor of grade 2. Coming to the discussion on neuroendocrine tumor, it is an epithelial neoplasm of appendix with neuroendocrine differentiation, and it will be peak in young adults and female predominance as in our case, and no specific symptoms. Usually 80% of this neuroendocrine tumor are incidental and not associated with carcinoid syndrome. Macroscopically, it is usually seen in the appendix and as a well-defined yellowish mass after fungal infiltration, and the mucosa is fat, and the usual size is less than 2 centimeters. And microscopy, small nest of nuclei and granular chromatin inconspicuous and eosinophilic cytoplasm. Extracellular mucin may be present in this tumor, and trabecular acinar pattern also may be present, and the clear cell morphology is very rare. And lymphatic perineural invasion is more common, but they have no prognostic significance. And uniform expression of chromogranin A and synaptophysin and broad spectrum of keratin, CDX2 positivity, and S100 cells may be positive in the sustentacular cells, and negative for these tumors are negative for cytokeratin 7, TTF1, and polyclonal PAX8. Coming to the grading of neuroendocrine tumor, grade 1 tumors will express a minimal nuclear atypia and mitotic figures of less than 2 per hyperfield and Ka67 index of less than 2. And grade 2 tumors usually have moderate atypia and mitotic figures between 2 to 20 hyperfield and Ka67 3 to 20%. And grade 3 being the cells showing marked atypia with mitotic figures more than 20%, 20 per hyperfield and Ka67 of more than 20%. Our patient has grade 2 tumors. Coming to the staging system, currently we are following 2 staging system, that is ENET guidelines and AJCC classification. In both it is the tumor of pathological.
Dr. Brinda, you're not audible.
Yes, sir.
The
Can you
audio is
hear me, ma'am?
Yeah, Brinda. Yes, you can continue, Brinda. Suddenly you went off. You were not audible.
Okay, ma'am.
Please continue. Please continue.
And appendicectomy. And the specimen 2, we had a urachal cyst excision.
Dr. Brinda, there's an echo somewhere. Suddenly you change your position or...
no, if she's using her headphone, ask her to remove that. She can just speak over the mic. instead
Yeah.
of using the headphone.
Yeah. All along you were nice, Brenda. All 20 slides came along well. Only the last 2 slides, the echo started coming. So you can just go back.
Now is it okay, ma'am?
You're fine, Dr. Brenda.
Okay, ma'am. So our patient had tumor of stage AJCC pathological stage PT1A.
She is not audible again, Valar.
Dr. Brenda?
She is not audible at
Yeah,
all.
yes, ma'am. Yes, ma'am. She's not audible at all. I'll check, ma'am. Give me a second.
Ma'am, can you hear me now?
Yeah. Continue, please. Continue. Brenda, please continue. We can hear you. We can hear you talk.
Yes, ma'am.
Yeah, please continue before it gets.
Ma'am, the second specimen what we received is the urachal cyst excision. And we found that a cystically dilated urachus filled with mucinous mucin-like material and lined by transitional epithelium and thin fibromuscular tissue. Ma'am. And usually it will be lined by urothelial or flattened atrophic or glandular type of epithelium, and this is consistent with urachal cyst remnants. These are all my reference, ma'am. Thank you so much.
Thank you, Dr. Brenda.
Dr. Brenda,
Any questions?
your appendix tumor, can it be a mucinous neoplasm of the appendix with neuroendocrine differentiation? Have you ruled out the mucinous adenocarcinoma with a neuroendocrine differentiation? Have you ruled out?
Yes, ma'am. Actually, because there was diffuse chromogranin positivity. That is why we ruled out.
Chromogranin positivity can be there when there is a neuroendocrine differentiation. But did you rule out? Because see, more common is the mucinous neoplasm. Of course, it used to be called as a mucocele of the appendix, but that is no longer applicable. Now they are all called a mucinous neoplasms, and can it be my question is whether it can be a mucinous adenocarcinoma with a neuroendocrine differentiation. Instead of calling it a neuroendocrine tumor, can it be a mucinous adenocarcinoma with a neuroendocrine differentiation?
We didn't think of mucinous adenocarcinoma, ma'am, because when we did think of mucinous adenocarcinoma and low-grade mucinous neoplasm, because there was so much of mucin. But the IHC, ma'am, showed chromogranin diffusely positive in all the cells. In mucinous adenocarcinoma, we will get only focal positivity of the neuroendocrine cells. But here the whole tumor was positive for chromogranin. And that is why we thought of neuroendocrine tumor over mucinous adenocarcinoma, ma'am. And there was an intact mucosa also, ma'am. The mucosa was intact.
But you said some glandular component was there in the sections.
Glandular component was there? Yes, ma'am. Glandular component was there. Very, very few glandular components were there. But the mucosa was intact. And
glandular component was benign.
Also, we did not see. Yes, ma'am.
There was no malignancy in the glandular component, Dr. Brenda.
There was no
But one thing, on latest treatment for adenocarcinoma.
Ma'am, yes, ma'am. There's a difference in the
Hello?
treatment for. Yes, ma'am. There's a difference in the treatment.
Valer, am I audible?
Ma'am, you're audible, ma'am. Ma'am, you can talk. You can talk.
No. Once I just asked the oncologist. Once I asked the oncologist for a treatment part of it, for adenocarcinoma and adenocarcinoma with neuroendocrine differentiation, he said no difference. So it's same medicine. So from that time onwards, the differentiation we used to mention, as Sita said, when adenocarcinoma cases with the neuroendocrine pattern, we used to put marker and confirm the component or the percentage of the neuroendocrine tumor. In that case also, madam is asking about the adenocarcinoma component. Have they done anything? The presenter, I think, what is she saying? I didn't understand.
Ma'am, actually what happened when we looked at the histology, the mucosa was not showing any signs of dysplasia or malignancy. It was only in the submucosa, and the tumor was infiltrating into the muscularis layer. The mucosa was intact and there was no dysplasia, ma'am.
Then where is the glandular component kind of tumor sections came from? Have you taken adequate sections?
Not glandular component, ma'am. They were mild acinar differentiation, ma'am. Very few cells were acinar differentiation. In our tumor, there wasn't any acinar differentiation.
That could be.
We just saw nests and trabeculae and pods of atypical cells. We did not see any acinar pattern. That Dr. Brinda mentioned in the discussion because
neuroendocrine tumor.
Yes, ma'am.
Yeah.
Yes, yes.
We can proceed with the next case.
Okay, ma'am. We can proceed with the next. Thank you, Dr. Brinda. This is from Stanley. Dr. Kritika, are you here? Dr. Brinda, that was a good case. Thank you, Dr. Brinda. So we go on to the next case, Dr. Kritika.
Thank you, ma'am.
You can share your screen, Dr. Kritika from Stanley. Kritika? If there's any issue, can we go on? Can you just get ready? We can go on with the next presenter. Dr. Surendra, then you can share your screen.
Okay, madam.
Yes, ma'am. You can take your time. You can present a little later. Hello.
Going to college, You can take it out. Take it out.
Good afternoon, madam. Is my screen visible and am I audible, madam?
Yes, ma. Yes, ma. You're visible. Your screen is visible and you're audible.
Thank you, madam. Good afternoon, all. First of all, I would like to thank my HOD, madam, Professor Dr. Arunlata, madam, and my professor, Dr. Valarmati, madam, for giving me this opportunity to present this case. So this is a case of 50-year-old postmenopausal woman with no comorbidities presented with swelling of left lower limb for 3 months duration, along with the pain for 2 months, bilateral breast mass for 1 month duration, pain in the bilateral breast region for 1 month duration. There is loss of appetite, but there is no fever or weight loss or any night sweats. So on head-to-toe examination of the patient, right breast mass is 4 by 5 by 4 centimeter, firm and tender mass present just above the nipple. Nipple retraction is present, and a nipple areola complex is involved, mobile, but not fixed to the underlying chest wall. Left breast swelling is 2 by 1 centimeter, hyperpigmented mass noted in the upper outer quadrant. And the left axilla shows 2.5 by 1.5 centimeter lobulated mass, firm, tender, and mobile. And there are two subcutaneous nodules, one below the right breast of size 0.5 by 0.5 centimeter, and other one is below the left breast. That was the excised specimen which came to the department. While seeing the patient, there was the excision biopsy scar. So this is the clinical image of the patient. This is one subcutaneous nodule. This is other subcutaneous nodule. These are the two breast masses seen in the patient. So we received the excision of one subcutaneous nodule and a true cut biopsy from both breast swelling. And in the lower limb, there is left lower limb, there is induration and swelling noted from toes to mid-thigh region, multiple swelling which was non-pitting and tender. One along the left mid-thigh in the ventral region and left mid-thigh dorsal region, right calf region, right mid-thigh dorsal region. Everything is around 2 to 1 centimeter in size. So this is the clinical image. Here we can see a swelling in the calf region and one in the mid-thigh. And one more swelling over the sacral region, which is also 1 by 1 centimeter firm swelling. So in imaging studies, USG breast shows right and left fibrogranular tissue with ill-defined hypoechoic lesion measuring 2 by 3 centimeter on right side and 2.8 by 1.4 centimeter on the left side. Birads was given as grade 3. CT chest showed similar lesions. It shows a multiple ill-defined soft tissue dense lesion, which we seen grossly. PET CT, because of multiple swelling, PET CT was taken for the patient. Impression was given as because of the multiple soft tissue involvement, the possibility of the lesion being lymphoproliferative disorder, which cannot be excluded. This was the impression given in the PET scan. So clinically, they proceeded with a true cut biopsy of both breast swelling and excision biopsy of the one subcutaneous nodule below in between both breasts. Investigations, CBC showed a reduced hemoglobin with normal total count and platelet count was normal. Peripheral smear finding is microcytic hypochromic anemia with no atypical cells. Bone marrow normal trilineage differentiation was seen. No blast cells was seen. So this is the true cut biopsy image of the breast lump. Almost both right and left was similar. It shows diffuse singly scattered infiltration of the atypical cells with a marked nuclear atypia and a scant cytoplasm. This is the image of the other breast. So we proceeded with IHC. It came as LCA diffuse and strong positivity. CK was negative in the breast and BCL2 was positive. So this is the IHC marker which we got. LCA and BCL2 alone is positive. Epithelial markers ER, PR, head to new, E cadherin and CK all are negative. This ruled out ductal carcinoma and lobular carcinoma. And though LCA is positive, we got a CD3 and a CD20. Both lymphoid lineage markers are negative, along with the CD117 also negative. So we left out with LCA positive and BCL positive alone. Then the abdominal excision biopsy came. It also showed similar feature with intact skin and a subcutaneous lesion with singly scattered neoplastic cells with a scant cytoplasm and a marked nuclear atypia was seen. In the IH was done for the abdominal wall swelling excision. CD10 and BCL2 came positive. CD45 also positive for the same case. It is also negative for CD3 and CD20. So common leukocyte antigen is positive, but the lymphoid lineage markers are negative in this case. So we we got one more true cut biopsy from the legs calf swelling. It also showed similar features. We can see the muscle bundle infiltrated with diffusely atypical cells with marked nuclear atypia and scan cytoplasm. So we stopped with this marker and we thought of some lymphoproliferative neoplasm without any, with the CD3 and CD20, there is no lymphoid differentiation. So with CD45 positivity, we gave IHC marker to the Apollo Hospital, and there we found MPO diffuse and strong positive in the atypical cells. CD43, which is also strong and diffuse positive in atypical cells, along with CD68, which is a histiocytic marker, is also positive in this case. So with CD45 and CD68 positive, along with the MPO and CD43 positivity, this is the final conclusion of the IHC marker. CD3 and CD20 was negative, that ruled out the lymphoid lineage differentiation. K67 is somewhat moderate of 30 to 35%, and CD99 was focal positive, CD43 and MPO was diffuse positive, CD34 is patchy positive, CKIT is patchy positive, LCA and CD68 was diffuse positive. So with these markers and myeloid with monocytic differentiation, we signed it out as myeloid sarcoma. So this case is presented here because of its rarity, and the treatment was completely different from the lymphoma versus the myeloid sarcoma. For lymphoma, we'll be giving CHOP regimen as starting, but for myeloid sarcoma, it will be cytarabine based therapy. So always myeloid sarcoma should be in consideration for multiple soft tissue involvement. A short note on myeloid sarcoma: it is a tumor mass consisting of myeloblast occurring at any anatomical site other than the bone marrow and distorts the normal tissue architecture. Although commonly associated with concurrent AML, myeloid sarcoma can occur in isolation. As we see in this case, bone marrow was clean and there is no myeloblast in the bone marrow. Only soft tissue involvement is presented. Based on the WHO classification, myelosarcoma must present as a tumor mass, as we see in our case, with the tissue architectural effacement. So these are the some published cases of myeloid sarcoma of the breast. It is a pathology that should not be forgotten, and this is one more case report of primary myeloid sarcoma of the breast. With the BCL2 positive in this case, it will be treated as a chemo-resistant myeloid sarcoma, which will be similar to the AML with chemo resistance. So the patient will be treated with anti-BCL2 therapy along with the cytarabine-based therapy. Thank you, madam.
So that was a very beautiful presentation, Dr. Surender.
Thank you.
Madam, can I give my comments on this case? This thing?
Sir, please, sir, please, sir.
See, the moment I saw this, first thing which I went through is that plasmacytoid dendritic cell tumor. Because of this.
Yeah, I was also thinking of the same thing. Dendritic
yes.
tumor was my first diagnosis.
Because there myeloperoxidase can be positive, doctor. Yeah. I think can I do that plasma dendritic cell tumor? Because there are two types in which one is mature plasmacytoid dendritic cell tumor, which will have a myeloid, which can have a myeloid neoplasm. Second thing is the blastic plasmacytoid, which is high-grade leukemia. Because with so many nodules all over the body, the two adult patient without I don't purchase the diagnosis of a chloroma. Are we looking at
Dr. Archana here, sir? I am the one from Apollo who had seen the case. So we did consider that as a differential. We did CD123, which came as negative, sir. CD123, which is a plasmacytoid dendritic cell marker, was done in this case, which is negative.
There's a panel now, doctor. Did you do panel TC4, CD123? What panels you did?
Yes, sir. See, everything was done, sir. It's actually CD123 is dot negative, sir.
Doctor, no, not doctor. See, I am not blaming your markers and all those things, but elderly person, you have got nodules all over the body, and I don't know, was bone marrow flow cytometry done?
Bone marrow was not sent to us, sir. I think it was.
The only thing is, no, I am not, see, it may be still chloroma, doctor, but no, I'm not able to accept chloroma. Still, are we missing something? That's what I need to look into the bone marrow, whether he has got MDS and all those things. So yeah, at this with such an extensive nodules, you cannot tell marrow is absolutely normal or smear normal and go for a chloroma, because see, the chemotherapy protocol for this dendritic tumor also is vague. It responds to the myeloid protocol. But as a purist, no, are we missing? Are we overlooking a plasmacytoid dendritic tumor? That's what my thought process. That's it.
So the bone marrow had just come in. Maybe we'll update it in the next meeting.
No, because going by myeloperoxidase, Kikuchi's disease also myeloperoxidase. Kikuchi is also myeloperoxidase positive. So we just cannot go with MPO. What other markers you had for diagnosis of chloroma, doctor?
Sir, CD34.
It is only patchy, madam. CD34 is such a vague marker, madam. It's only patchy, no?
But it's a primitive markers. It has come. So
No,
I mean,
no,
yeah,
no,
you might be right. Yeah.
It is only patchy. See, it is only patchy. That's what. If you tell it is strong positive, then I accept it. It's only patchy, doctor. You cannot accept it. So please, no, this is my thoughts, doctor. No, I just don't want to go further. Think about it. That's it.
Okay, sir. Okay, sir. Definitely, sir. Hello.
Well, another conflicting point is the involvement of both the breast. I don't know how common it is to have a chloroma involving the breast tissue. I don't know. After Krishna Kumar only to tell us.
Madam, I have seen chloromas in the orbit, madam.
That's what I'm saying. That is what I'm saying. See, granulocytic sarcoma or the so-called myeloid sarcoma is, I don't know how common it is involving both the breast.
I think can get some cytogenetics done. Usually 8, 16, 8, 21.
But MPO is positive, no, KK? MPO positivity is not.
What?
MPO is positive, right?
No, MPO is positive in blastic plasmacytoid dendritic tumor also. Kikuchi's disease, MPO is positive. Whenever the dendritic cell comes from the bone marrow, MPO is positive. Just don't go by MPO. That's what my suggestion.
Sir, in this case, bone marrow showed evidence of infiltration, sir. But cytogenetics and all that was not done. It was not.
Madam, what infiltration? Madam, because what
the same kind of cells. No, the same kind of cells in the bone marrow. What
no, madam. No, because when you see the revised classification of dendritic cell tumor, there could be benign plasmacytoid dendritic cell tumor with myeloid neoplasm, not leukemia. The second is blastic plasmacytoid. Patient would have been wasted and none gone to death. It is a very rapidly progressive tumor, madam. Without chemotherapy, the blastic plasmacytoid will go away. So we need to know what is that bone marrow component.
It showed similar, no other special investigation was done, but it showed the similar kind of cells as in the abdominal wall and in the leg.
Then you are looking at a plasmacytoid dendritic cell tumor of some subtype, madam. I am not sure about it. Show it to some experts who have diagnosed this thing. That's what my suggestion, madam.
What are the other markers, sir? What are the rest of the markers?
Madam, usually they do a panel, madam, because recently we had one case, couple of months back, we had a case from Chandra Medical Foundation, and that also we had a similar dilemma because the lady had leukemic cells in the smear, but marrow was not acute leukemia. She had multiple nodules in all over the body. That was from Chandra Medical Foundation, Dr. Then the slide came to me. Initially the diagnosis was a lupus tumidus from outside. I'll not tell the thing. Then looking at the morphology, I said, looks like benign, mature dendritic cell tumor with myeloid neoplasm. That was the diagnosis we gave. So we need to subtype it correctly, madam, for a chemotherapy protocol and thing. So this pure chloroma will not accept it, madam. That's it.
KK, Dr. KK, this is Vijayashri.
Yes.
Will CD56 suffice? They should have added only CD56 probably in their profile.
Madam, see, what I understand is, I recently remember Dr. Sandhya's talk from WHO. They said, you don't do panels doing only one marker. Even retinoblastoma, CD56 is positive, doctor. No, so one marker business I will not go. That's
but they have done an entire panel and they have included, I think, CD56 in their presentation.
Doctor, no. Only thing is my thoughts. I just tell I cannot accept chloroma from this thing. Morphology cells are spindly. We are looking at a dendritic cell tumor, some subtypes.
No, the cells were not very spindly at all. Maybe in the photograph, the cells look more of round oval. Like,
ma'am, no, not like that. This is not the way in which scleroma presents, madam. That's what I'm telling, ma'am. Because in this age group, dendritic cell tumors, that subtype is more common, madam. That's all.
Okay, so we'll take your suggestion. We'll go ahead with more markers and we'll get back, sir. Okay. Thank you, sir. Thank you. Thank you. That was a nice presentation, Dr. Surender. Anyway, we'll it's just half done. We'll go ahead with more markers and we'll get to
Okay.
our process.
Thank you.
Thank you, Surender. And Dr. Kritika, are you ready? Can you share your screen? Kritika, please share your screen. Oh, hello. Dr. Kritika, yes? Can you share your screen, ma? Or do you need some time? Yes? Dr. Kritika? Something wrong? Or can we go on to the next presenter, Dr. Geeta Priya? Dr. Geeta Priya from Chettinad Medical College.
Ma'am, shall I start sharing screen?
Please, please, please.
Ma'am, is my screen visible, ma'am?
Yeah, Dr. Geeta Priya, you're audible and your screen is visible.
Thank you, ma'am. I thank my HOD, Dr. Vijayashree ma'am, and the esteemed faculties of the City Pathology Meet for giving me the opportunity today. Moving on to our first case, patient is 57-year-old male who came with complaints of inability to walk. He was subjected to MRI and there was an intradural extramedullary lesion at D10, D11 levels. So grossly, the lesion was excised and sent for histopathology. Grossly, we received a cystic structure measuring about 1 into 0.5 centimeters, which was gray-white, and on cutting open, it drained clear fluid, all of which were embedded. Microscopically, this is a low power view. We saw cyst wall lined with cuboidal to columnar epithelium with underlying fibrocollagenous tissue. Going on to higher magnification, we were able to see some cilia, the cuboidal to columnar epithelium with cilia with interspersed mucin secreting cells. And we went on to learn about the cysts of neuraxis. These are all these neuraxis, which is listed as the colloid Rathke's cleft cyst, intraspinal cyst, epidermoid, dermoid cyst, glioependymal, chloroid plexus, simple or gliotic cyst, penial cyst, arachnoid cyst, dural cyst, juxtafacet ganglion cyst, and synovial cyst. The highlighted ones can occur in the spinal cord. Few points for differentiation. Coming to the neuroenteric cyst, which is the spinal cord, is the most common location. It is usually intradural and extramedullary. Commonly, the microscopic feature here is columnar to cuboidal epithelium with goblet cells with or without cilia, which is presenting like our case. And ependymal cyst, which is usually intracranial, supratentorial, and paraventricular. This will also have columnar to cuboidal epithelium, but without goblet cells. Rat case cleft cyst, it is intracellular or supracellular, presenting with columnar and cuboidal epithelium without cilia and goblet cells. Colloid cyst occurs at the third ventricle near the foramen of Monro, which will also have columnar to goblet cells. Coming to the arachnoid cyst, which is usually supratentorial, sometimes it can be seen intraspinal in the spinal region, which will have a flattened meningothelial lining epithelium. Epidermoid cyst common at the cerebellopontine angles, and it will have keratinizing squamous epithelium. And dermoid cyst will have keratinizing squamous epithelium with adnexal structures. So looking at the histological picture and the location of the lesion, we took the differential diagnosis of the first one as intraspinal cyst, which has 0.7 to 1.3 percentage, which comprises about 0.7 to 1.3 percentage of spinal axis tumors, usually occurs as a solitary lesion. This occurs because of incomplete separation of the developing endoderm and the notochordal tissue. 90% it is intradural and extramedullary, similar to our lesion. It is also called as neuroenteric cyst, foregut cyst, enterogenous or teratomatous cyst. It occurs anterior to the spinal cord and it has a 30% of recurrence rate. It doesn't depend upon the site or the size of lesion. So this is actually classified into 3 types depending on the histological picture. Type A, it is lined by a single layer of pseudostratified columnar epithelium, which is similar to the respiratory or GIT epithelium. Type B will have complex invaginations along with glands like with serous and mucin secretions, nerve bundles, smooth muscles, fat and cartilage elements. And type C will have ependymal or glial tissues. So next one in our differential is the glioependymal cyst, which arises in the paraventricular white matter and the frontal and parietal lobes, followed by cerebellum, brainstem, and spinal cord. So this is actually developmental displacement of the ventricular lining epithelium, lined with ciliated columnar epithelium without goblet differentiation, and it will not rest on the basal lamina. It is directly opposed to the fibrillary neuroglial tissues. Our next differential is the arachnoid cyst, which is common in the sylvian fissure, followed with cisterna magna, cerebellopontine angles, and at last in the spinal cord. It is just loculated accumulation of CSF with the fibroconnective tissue lined with attenuated meningothelium. And our last one is the ganglion cyst, which is just acellular myxoid material within the fibrous capsule, devoid of any lining epithelium, common in the lumbar spine, followed with the cervical spine region. So we proceeded with immunohistochemical markers. We have put pan-CK, which showed 100% positivity in the epithelial lining here, and GFAP, which showed negative in the epithelial lining. So we have concluded this as a neuroenteric cyst type A, which is a simple cyst lined with columnar to cuboidal ciliated epithelium with intervening mucin secreting cells. It is into type A because it did not have any glands which secrete serous or mucinous secretions or any other elements. We have just named as neuroenteric cyst type A. Moving on to my next case for today. Patient is a 20-year-old male who presented with 5 into 4 centimeter swelling on the left side of neck along the posterior border of sternocleidomastoid muscle, which is present for the past 2 years and progressively increasing in size. Patient was subjected to MRI contrast, which showed a cyst in the posterior triangle, query infected branchial cyst or cystic schwannoma. CT neck also showed a posterior triangle, query lymphatic origin cyst or infected branchial cyst. CT and MRI showed normal thyroid gland. We received a brown cystic structure measuring 4 into 2 centimeter. It was gray brown. On cutting open, it let out serous fluid. Peripherally, there were few attached fibrofatty tissues. There were no solid areas or papillary excrescences, and cyst wall thickness is 0.2 to 0.3 centimeters. Histologically, low power view, we saw the proliferating epithelium forming a papillary pattern and the underlying fibrous stroma with edema and a few calcification-like areas were there. Going on to higher magnification, this lining epithelium was showing overlapping crowding of nucleus, and a few dystrophic calcification areas were also seen, and orphanani appearing nucleus is also there. We also saw certain cells with intranuclear grooving, and adjacent cyst wall showed normal thyroid follicles filled with colloid. So, and we also had a lymph node which is attached to the cyst, which is showing sinus histiocytosis. This lymph node was well encapsulated. And we have given a diagnosis of papillary carcinoma in ectopic thyroid. A few points about ectopic thyroid. It is the most frequent form of thyroid dysgenesis, which accounts for about 50% of case. Its prevalence is 1 in 3 lakh population. Autopsies suggest that 7 to 10% of adult will have remnants of thyroid tissue along the path of the descent. So male to female ratio is 1:4, and which may occur at any age group from 5 months to 80 years of age, more common in the younger age group. So the area in between the lower part of the mandible through the neck to the aortic arch is called the Wolfler's area. This is the commonest site for thyroid ectopics, and sites in descending order of frequency. Lingual thyroid is the most common type, accounting for about 90% of case, followed by the thyroglossal duct cyst, which accounts for 20 to 60% of cases, and neck midline organs like larynx, trachea, and superior mediastinum, followed by sometimes we see benign thyroid follicles in the perithyroid soft tissue regions and in the muscles, often around the isthmus, which is all silent and harmless. Non-midline sites include salivary glands, retropharyngeal space, cervical lymph nodes, and branchial clefts. This is a picture for distribution of ectopic thyroid. This is the lingual, sublingual, prelaryngeal, normal location, and this is from the substernal side. So coming to the pathophysiology, it occurs because of either too fast descent or too slow descent of the gland. Attachment of thyroid tissue, if it is happening even before the migration of great vessels, and ectopia in thorax and upper GIT, it is because of the foregut developmental anomalies. Ectopia in submandibular and lateral neck region, it is because that the lateral component does not migrate and fuse with the medial thyroid enlarge. So genetic inheritance has also been reported causing heterotopia in animals, but no mutation in known gene has been so far associated with human ectopic thyroid. Rarely familial cases have been reported. This is a case report which shows dual site thyroid ectopy in a mother and son. According to this case, published around 2009, there were 10 cases of ectopic thyroids happening in blood relations. Coming to the clinical features, it is usually incidental, asymptomatic, which has got only pressure symptoms. It will increase in size during puberty and pregnancy. Ectopic thyroid tissue will sometimes be the only functioning thyroid tissue in 50% of cases, particularly if it is a lingual or cervical ectopic, and may present with same disease as the eutopic gland, like inflammatory and neoplastic conditions. Diagnosis, thyroid cancer metastasis should always be considered before should be ruled out before accepting a diagnosis of ectopic thyroid. To rule out malignancies, we'll have to do imaging with radionuclide scanning and CT MRI and ultrasound with color Doppler. Prognosis wise, ectopic thyroid malignancies have good prognosis compared to the normal thyroid malignancies, and it has very low chance of recurrence after surgical excision. So if any morphological signs of malignancy are identified, then diagnosis is metastatic papillary thyroid carcinoma until proven otherwise. So personal history of malignancy or the absence or normal thyroid gland, no past history of thyroid surgeries should be ruled out. Sometimes metastasis from ectopic thyroid carcinoma should be considered. There are specific immunohistochemical markers like galactin, cytokeratin 19, and HMB-E1. These markers will be positive if it is a malignant primary or a metastatic foci, and the normal-looking thyroid follicular epithelium, which is adjacent to this metastasis. But it is negative in the normal-looking follicular epithelium, which is adjacent to the primary ectopic carcinomas. So this is from the article. We had one other thyroid ectopic case. So this is a 29-year-old female who presented with right hypochondrial pain. We have diagnosed as chronic cholecystitis with ectopic thyroid tissue. The wall of the gallbladder showed thyroid follicular cells lined with low cuboidal epithelium with colloid filled, which is all colloid filled. Gallbladder ectopics, only 8 cases has been reported in literature as of now. Thank you.
Thank you, Dr. Geeta Priya. They were beautiful cases, and Ectopic in the gallbladder is very rare. Haven't seen so far. Any comments, ma'am?
Sorry, I couldn't listen. I was out. I only joined now. Was it the gallbladder ectopic?
Yes, ma'am.
No, no.
How did it reach the gallbladder?
We had two cases, ma'am. Actually, we received a cystic lesion from lateral aspect of neck, and that showed.
You mean ectopic thyroid?
Yes, ma'am. Yes, ma'am.
Oh, I thought when
Thyroid
she
in
said
gallbladder.
ectopic, when she said ectopic, I thought it was ectopic gestation.
No.
Okay, ectopic thyroid. Okay. Is it ectopic or thyroid was normal?
Thyroid was normal in both
Lingual
cases.
thyroid.
Normal, ma'am.
How come thyroid there near the gallbladder? That is.
So, is there any literature reference?
Ma'am,
8 cases reported,
8 cases
madam, in
reported in
gallbladder.
literature. ma'am.
Oh, okay. Something extremely uncommon. Okay.
Thank you.
Bringing out
Dr.
these
Thank you
cases
for
are
that.
very good, actually. Someone come across cases like this will be an eye opener.
Yeah, it's an eye opener for all, ma'am. Yes.
Yeah.
Thank you,
Point
Dr.
to be
Prakash. Shall we go on to
documented.
Dr. Yes, ma'am. Shall we go on to Dr. Archana from Apollo?
Yes,
Last
ma'am.
case, huh?
இல்ல மேம் இன்னும் ஒரு கேஸ் இருக்கு டாக்டர் கிருஷ்ணகுமார் கேஸ் will be the final.
Okay.
Dr. Archana?
Ma'am, it's not letting me share, ma'am.
Yeah.
Okay, now I think I can. Ma'am, can you see my screen, ma'am?
Yeah, your screen is visible and you're audible. Please continue.
Yes.
Welcome.
Thank you, ma'am. So this is from a patient, a 58-year-old woman who presented with altered bowel habits, and colonoscopy showed polypoidal growth in the cecum. Actually, it was all evaluated somewhere else. And biopsy was reported there as poorly differentiated malignant neoplasm with extensive necrosis. The outside slide was submitted to us because it looked polypoidal, but it was reported as probably a spindle cell neoplasm, and also they just submitted it to us for review. And this is how the specimen looked. As you can see, around the vessel, some viable areas, the rest are all kind of necrotic and edematous. Little hyper view, lot of necrosis. These are short spindle cells, epithelioid to spindle cells, lot of fibrinoid blood vessels, and here and there few mitosis were there. So since being a spindle cell neoplasm, the first thing that comes to mind is to rule out GIST. So we headed towards the immunohistochemistry. So basically CK was negative and Vimentin was diffusely positive. Desmin was negative. SMA is, we consider as negative. Sometimes in some cases it comes as nuclear positivity, which we ignore. We will take only cytoplasmic positivity as positive. And being colon, so we wanted to rule out GIST, so we did CKIT and DOG1, both were negative. CD34 is also negative. Some blood vessels are positive. So if you see synaptophysin, some of the cells are showing cytoplasmic dot-like positivity. And S100 is beautifully positive, diffusely positive. Since S100 came positive, we had to add SOX10, which also came positive. So now is it neural? Are we dealing with neural? But synaptophysin was dot-like positive in some areas. So CD56 was also positive. It was positive in more than 50% of the neoplastic cells. So on morphology, it's an extremely necrotic. It had spindled and epithelioid morphology. It's mitotically active. And it was positive for Vimentin, S100, SOX10, CD56, and focally positive for synaptophysin. So basically, with spindle cell, we had to rule out is it GIST, so CKIT and DOG1 negative. And the next thing is, since S100 and SOX10 was positive, are we dealing with some kind of spindle cell melanoma? I know it's a rare site and there was no melanin and all. So we basically, to rule that out, we did MART1 and HMB45 as well, which was negative. And I always consider the dendritic cell neoplasms as a differential. Unless we think about it gently, we would miss it because it had a little different morphology. For that purpose, I had added CD21 and 23, which was again negative. And to rule out MP and ST, I had added, actually, I didn't put in this H3 K10 and ME3, that was retained, that was not lost. So it's basically expressing some neural and neuroendocrine markers. So hence we favored a diagnosis of malignant gastrointestinal neuroectodermal tumor, also called as gastrointestinal clear cell sarcoma. So then further, they did PET CT. Since we gave diagnosis of sarcoma, they did PET. So PET was restricted to that cecal growth with few pericolic lymph nodes, and right hemicolectomy was done. And we received a specimen of right hemicolectomy. As you can see in the cecum here, you can see the ileocecal valve. Cecum, it's purely a polypoidal lesion. Cut surface was very much fleshy. These areas were not going into the pericolic adipose tissue and all. Some bigger nodes were there, but nodes were just reactive. It was not involved. As you can see, this is a spindle cell lesion. The way it is pushing itself towards, it's basically like just it was seen in the muscle, but it's pushing its way through the submucosa into the lamina propria. On low par, you can see it has this alternating low hypo and hypercellular, dark looking and pale looking areas. In pale looking areas, the cells were little epithelioid, and dark looking, it's more spindled out. In hypercellular areas, there are sweeping fascicles of spindle cells, lot of mitosis, and we could find areas of necrosis. Again, these fibrinoid vessels, as we saw in the small biopsy. This is a higher par view. You can see spindly nuclei and scattered mitosis. As you can see in this par only, there are about 4 or 5 mitosis per high par field. So it was quite mitotically active. So I just wanted to repeat few immunostrains, so we didn't charge for that. So we did that in that small biopsy number only. So S100 came beautifully positive, SOX10 came beautifully positive, CD56 again was like nicely positive, but synaptophysin came again in a subset of cells, that too like cytoplasmic dot-like positivity. Hence we again favored the same diagnosis. It's a malignant gastrointestinal neuroectodermal tumor or a gastrointestinal clear cell sarcoma. So this is a sarcoma involving a GI tract with neuroectodermal differentiation, the most commonly seen in small intestine, stomach, and then colon. It's commonly seen in young adults. There's no sex predilection. Grossly, should give us a clue that it often presents as a polypoidal mass. Histologically, it can look like anything. It can be short spindle. It can be looking like a gist. It can have a round cell morphology. Can have a epithelioid morphology. So although the name suggests clear cell sarcoma, you can find clear cells very focally. Most often we will find pale eosinophilic cytoplasm. Clear cells can be seen very focally, and it can be variably mitotically active. Not necessarily it has to be very mitotically active. So IHC wise, since it's neuroectodermal, so it's neural markers positive, and neuroendocrine markers are positive. Generally, it stops at synaptochromo is not expressed, and other melanocytic markers are negative. But there are case reports where melanocytic markers can come in a subset. So basically, to call it as a GI clear cell sarcoma, we have to rule out melanoma elsewhere or a clear cell sarcoma of soft tissue before considering this as primary in cases where melanocytic markers come positive. So molecular pathology wise, they express EWS-R1 aberrations. The fusion partners can be ATF or CREB1. Prognostically, it's an aggressive neoplasm. They frequently have nodal and liver metastasis. In our patient, it was discussed in multidisciplinary team meeting, and it was decided to give chemotherapy. I'm really not sure about the details of the chemotherapy though. So the patient will be put on follow-up to look for any future metastasis. Thank you.
Dr. Archana, that was a wonderful case.
Thank you, ma'am.
Any comments, any discussion, ma'am?
I thought it is looking like a basaloid leucogenic pattern commonly seen in the anal canal of esophagus. This
Yes, ma'am.
present histologic similarity was seen at the cecum is quite unusual. What is the others' opinion?
Because you have heard about the
What
clear
about-
cell sarcoma of the soft parts, but then GIT. This is a new entity, Dr. Archana.
Newer entities, ma'am.
Ma'am, previously it was called as clear cell sarcoma, like sarcoma of GI tract, ma'am. It has been renamed as neuroectodermal tumor.
Yeah, that is what, because I think melanocytic differentiation is even when we consider a soft tissue tumors of the clear cell type, the so-called soft tissue clear cell sarcoma, we always think of a melanocytic differentiation. So,
Yes, ma'am. Yes, ma'am.
So I don't know whether melanocytic markers were negative in this case, right?
It was negative, ma'am. HMP
Yeah,
45. And yes, ma'am.
I saw the slide. Anyway, it is one of the new entities, and I think everybody should be aware of this, especially when we have, as you said correctly, whenever we see a spindle cell tumor in any of the GIT, we are carried away with GIST.
True, ma'am.
So I think we should consider the other possibilities also. So that is a very important eye opener that we should consider any spindle cell neoplasm.
Palisading
I think we should
pattern.
do a melanocytic differentiation as well as the neuroendocrine differentiation. That is the take-home message for all of the
Why
young
the
people.
pattern of like a peripheral palisading madri varudhu? Why it is coming?
It was not peripheral palisading, Eril. It was more of diffuse sheets of cells.
Condensation.
Yeah, but
Condensation
I
of
wouldn't call it a palisading. It was mostly in something like a crisscross or a diffuse
Crowded.
manner. Yeah, I don't think you can call it a palisading pattern
A
as you
low-
find in a
a
schwannoma.
low
or something
power
like that.
basaloid or a basis squamous. We say if it is from the rectal aspect, we think of that. I mean, low power. After the marker and then the high power totally
No, it has
changed
more
to us.
spindling. It is more
Yeah.
spindling. Really, it is not a
Yes,
basaloid
yes,
character.
Yeah.
It is more of a spindle cell type. Yeah. So
That
anyway,
pattern
that was a good case.
Thank you, ma'am. Thank you.
So thank you, Dr. Archana, for that highlighting on the latest ones.
Thank you. Thank you for the opportunity, ma'am. Thank you.
Thank you. Can we go on to the next presenter, Krishna Kumar sir? Sir, are you ready?
Yes, doctor.
KK, you have not slept, no?
No, madam, I am just sitting and report.
So before we start, I have a small clarification, sir. So with you, sir, we were just discussing about that myeloid sarcoma. So myeloid sarcoma and just CD123 or CD56, they are the dendritic markers. Are the negative? The negative இருக்கு சார் அந்த கேஸ்ல we have done those markers CD123 and CD.
Madam, I am not telling. But
இல்ல at least for the patient's sake we have to know, no sir.
No, madam,
And CD sir நான் முடிச்சிடுறேன் ஒரு நிமிஷம். CD43 and CD68 வந்து they are highly specific for myeloid sarcoma. அது பாசிட்டிவா இருக்கே சார். இல்ல it's a doubt. உங்ககிட்ட clarify பண்றதுக்கு தான் நான் கேக்குறேன்.
Madam, நீங்க சொல்ற பாயிண்ட் கரெக்ட் தான் மேடம். Because of the looking at the way so extensive lesions, madam, and marrow not involved. Only thing is
marrow showed infiltration, sir. We didn't do any special investigations for the marrow because of the cost value. So idoda
madam, inga da na solren marrow infiltration na, because when you see this plasmacytoid dendritic cell tumor, there is the two types are there. In one type, there is going to be a marrow infiltration. So that's what. See, it may be chloroma, but I will want to exclude whether are we looking at a plasmacytoid dendritic cell tumor. I am not talking blastic. Plasmacytoid dendritic cell tumor with myeloid neoplasm in the bone marrow. That's what my thought process. Because you don't get extensive chloroma lesions all over the body, and Madam, I have never come across or read anything like this, madam. That's the reason, no, I was concerned. That's the thing.
Okay, sir. We'll go ahead with the other markers and then we'll get it.
Yes,
We'll
madam.
get back, sir.
Yes,
Thank you, sir. Thank you. So you can start your.
Yes, madam. I never want to talk. No, suddenly, no. Somehow, sorry for disturbing.
No, sir. Only when you say we can clarify. At least we can get a better diagnosis for the patient.
Okay, madam. So let me. Thanks a lot. Good afternoon, all of you. Thanks a lot for the opportunity. And the first case is referred by Dr. Suresh. This lady in 2019, she was around, I think around 19 or 20 years, had a plaque in the thigh, diagnosed as paniculatis in Coimbatore. This is the 2019 biopsy where they thought in terms of a perivascular granulomatous and mixed inflammation in the subcutaneous fat. And they thought clinically whether it is erythema induratum or nodular vasculitis. They thought in terms of tuberculosis. I never had a chance to review those slides. We only got the report from the patient. 2022, after marriage, within 3 months, she has got this erythematous plaque on the thigh and near the knee. And 3rd month of pregnancy, it started becoming something like a tumorous lesion like this in the thigh and around the knee, and she was treated with for infection by the local dermatologist. And finally, she landed to the surgeon, and biopsy was done and sent to us at Shankar Netralaya. Looking at it, we know there was a dense infiltrate of blue cells in the dermis. It is definitely going to be some type of malignancy. There is not much epidermotropism. I did not get fat in the biopsy. The entire dermis was occupied with these round cells. I know we are looking at hematolymphoid neoplasm. And then we had no time to waste, so I just sent it for a base level markers, and the predominantly CD8 markers are positive. So we suggested whether this could be cutaneous T-cell lymphoma of subcutaneous pancreatic T-cell type. I know because I have seen a couple of subcutaneous pancreatic T-cell lymphomas. We never see such extensive dermal infiltrate. The patient was referred to an oncology center. The only worry I had is whenever we see this aggressive CD8 lymphocytic infiltrate in a biopsy, this is really very worrisome for me, because a whole lot of clinical conditions can have the CD8 positive, whether this is hypopigmented mycosis fungoides, localized pagetoid reticulosis, lymphomatoid papulosis type D, some cases of anaplastic large cell lymphomas, CD8 aggressive epidermotropic T-cell lymphoma. The other panels must have been done at other oncology center. I have no idea. Gamma delta T-cell lymphomas, subcutaneous pancreatic T-cell lymphomas, some indolent lymphomas like CD8 lymphoid proliferation of the ear, and pleva can also have CD8. So I thought, no, because this patient was sick, she was getting very anemic. We sent the patient to oncologist with a diagnosis of CD8 positive lymphoma. Definitely, I have not subtyped properly. I know this is not pancreatic T-cell lymphoma, some sort of a peripheral T-cell lymphoma. So I want to know the inputs from the general pathologists and other seniors. How do they deal with these sort of cases? Hello?
I think, Krishna Kumar, you should ask the oncologist to whom you sent the patient.
I will get the follow-up, madam. This has happened a
because
couple of weeks
we
back.
are not competent enough to comment on the modality or the progression, or see what you have listed is okay. Like all of them can be CD8 positive, and it very much looks like your subcutaneous paniculatis T-cell like lymphoma. I agree with you.
Madam, but what happens now? In the dermis, we never get this infiltrate. And, the alpha beta is not so aggressive at all like this.
So I think you should talk to the oncologist who's treating and how they are progressing, and what are the other ways by which they exactly come to a diagnosis, and what difference does it make in the treatment modality. I think all this is to be answered by the oncology department.
I will get back to you, madam. Okay. Yeah. The second case is patient had multiple papules and annular lesions in the neck. And so you see, this is an acanthotic epidermis trying to, like a claw, it is holding on to the hair follicle and inflammatory cells. This is one of the perforating folliculitis. It comes under perforating dermatosis. A whole bunch of disease spectrum is there. Primary perforating dermatosis and acquired perforating dermatosis. This is just for the people to aware of this perforating dermatosis conditions. Kidney renal failure commonly have presence with perforating dermatosis, etc. Coming to the third case, this lady was having psoriasis for a long time, and she had come this time because some of the patches were not responding to treatment, and so referred to Chennai Skin Foundation, and then we were puzzled why psoriasis is not responding to treatment. So Dr. Murug Sundaram is the treating doctor, and this is old patient of Dr. Professor Patrick Kosirian. So biopsy was done and sent to me with psoriasis. Looking at it, I found an acanthotic epidermis with the neutrophils in the superficial layer, but the epidermis showed nuclear atypia and occasional mitotic activity. So I was a bit concerned. I called Dr. Murug Sundaram and told, hey, this does not look like psoriasis. This looks something like a Bubans or some atypia is there. Can you get us more information? So, but he was insisting this is psoriasis treated in the US. So I gave a report of psoriasiform dermatitis with diskeratotic cells. I was hesitant to put Bubans when they are all talking psoriasis. So we discussed the case. Then we came to know that lady was taking native medicine in the US, and Professor Vesurian suggested they could be using arsenic. Arsenic induced psoriasiform lesions, which are about to get transformed into Bubans, can have this pattern. So we have asked for a hair and nail analysis of arsenic. So the patch of the biopsy, which was diagnosed as possible Bubans, was treated with cryotherapy. The dilemma arose is, must we do biopsy for all the patches? So we have communicated the results to our doctor in the US, and we are waiting, asking the patient to come back once the arsenic levels comes. The other thing is, we have no idea whether she is on PUVA therapy. PUVA therapy also can produce diskeratotic cells. So this is something first time I'm seeing psoriasis-like presentation, but not responding to treatment. We need to keep in mind whether the patient has got an arsenic, she's on arsenic, which can produce a Bowenite changes, or a PUVA therapy, Sorolin plus UVA therapy, which is going for psoriasis, where you can get atypical lesions. This is something, a learning experience for me. I thought I'll share this case with the senior people. Next is from Netralia, a painful blind eye. Man has lost the vision and eye was eviscerated. We get the cornea, uveal tissue, and the sclera is kept inside. And this is for people who are not used to eye pathology. This is the eyeball. So when I tell evisceration, the sclera is kept. The intraocular contents are removed. So I am now talking about the retinal tissue, the retinal pigment epithelium, and choroid. You see the biopsy. This is Zeal-Nielsen pigment. You can see the retinal lamination still preserved. The black pigments is the retinal pigment epithelium. And you find multiple numerous clumps of acid fast bacillus in the retinal tissue, which shows necrosis. And this is the AFB is also, the acid fast bacillus is also seen in the retinal pigment epithelium. You find a multinucleated giant cell here. Once again, numerous acid fast bacillus in the retinal pigment epithelium. So this was intraocular tuberculosis. But how does tuberculosis spread to retina and subretinal pigment epithelium? Wonderful work done by people where the retinal pigment epithelium is something like a storage for a mycobacterium tuberculosis, and it immune mediated, it safeguards the bacteria, it saves. Another work where the drugs don't reach the retinal pigment epithelium. So once the patient gets immunosuppressed, the tubercle bacillus spreads. Thanks a lot. These are the 4 cases from my side.
Membership one time.
Excuse me, somebody is there.
It's okay. Don't worry about the cost.
High pressure AC service. அதுதான் வந்து அந்த பேக்கேஜே வந்து 3000 rupees.
Somebody, can you mute your mic?
Okay, I finished my 4 cases, doctor.
So thank you, sir. Thank you, sir. The beautiful set of cases, and the last case, especially the last one. Ma'am, anything to any thoughts on these cases, ma'am? Sir, Krishna Kumar, sir? Sir, on the last case, konjam represent panna mudiyuma, sir, because there was so much of disturbance at the...
Okay, madam. Sure, madam.
And the TB of the eye.
கண்டிப்பா செய்யறேன் மேடம் நான்.
There's a lot of crosstalk there.
தெரியுங்களா இப்போ?
Yes sir, yes sir. Young man.
This was a young boy aged 24 who's had a painful blind eye and the eye was eviscerated. Evisceration na வந்து the sclera is kept and the intraocular contents removed and submitted for histopathology. For people who are not exposed to eye pathology, when I tell eviscerated now, I get the retinal tissue, the retinal pigment epithelium and the choroid, vitreous cornea. So இது வந்து Zeal-Nielsen stain. இந்த பிளாக்கா இருக்கிறதெல்லாம் ஆரோ போட்டிருக்கிறது வந்து ரெட்டினல் பிக்மெண்ட் எபித்தீலியம். அதுக்கு முன்னாடி இருக்கிறது வந்து பாத்தீங்கன்னா ரெட்டினல் டிஷ்யூ. அந்த ரெட்டினல் லாமினேஷன் ஒன்று இன்டாக்டா இருக்கு. மல்டிபிள் கிளம்ஸ் ஆஃப் ஆசிட் ஃபாஸ்ட் பேசிலை ஆர் சீன். இது கொராய்ட். கொராய்ட்ல வந்து பாத்தீங்கன்னா வந்து ஃபுல்லா நெக்ராட்டிக்கா இருக்கு சாரி பிக்மெண்ட்ல. இது வந்து பாத்தீங்கன்னா ஹை மேக்னிஃபிகேஷன். இந்த ரெட்டினல் லாமினேஷன்லயும் அங்க கிளம்ப்ஸ் ஆஃப் ஏபி இருக்கு. அந்த ரெட்டினல் பிக்மெண்ட் எபித்தீலியம் இந்த கருப்பு கருப்பா இருக்கு பாத்தீங்களா, அதுல வந்து யூ ஃபைண்ட் bacillus are seen. And once again, you find multiple clumps of acid-fast bacillus in the retinal tissue and also in the RP, sub-RP layer also this is seen. How does tuberculosis comes here into the intraocular component? Because this guy all the time, this boy, anterior chamber aspirate PCR negative, vitreous PCR negative. But when the eye was eviscerated, histopathologically we are finding so much. What we see from literature is the tuberculous bacillus from the lung goes through the blood circulation, through the choroidal vasculature, enters into the retinal pigment epithelium. Retinal pigment epithelium is like a macrophage. It like something like the lepra bacilli stays inside the macrophage. The tubercle bacillus stays inside the macrophage and it has got an immune privileged site. It is sitting there. So it is not targeted by any therapy. Once there is any immunosuppression, local immunosuppression, when the doctors give intraocular steroids, there is immune suppression and the bacillus starts multiplying and goes to the retina. This work was demonstrated by Dr. Narsingh Rao in 2014. Is my teacher. That is, the Mycobacterium tuberculosis multiplies in the retinal pigment epithelium and waits for an opportunity. Then they enter into the posterior segment, producing granulomatous inflammation and tuberculosis in the retina and vitreous. So this was a case we saw recently. I thought let me share that infections are still there and tuberculosis is also there in the eye. Okay, doctor?
Sir, thank you very much, sir. Thank you very much.
Sir, I have one question. Couldn't we have treated this case, therapeutically with medicines? Should we go in for whatever you called it, removal of the eyeball, not the eyeball? Should we have done that?
Madam, see what happens.
Yeah, evisceration. Should we have done that?
Madam, this boy has come from Bangladesh. They had diagnosed, gone everywhere. They diagnosed as posterior uveitis, not responding to therapy. Finally, he's lost the vision. So it was very, very painful. So as therapeutic procedure and for cosmesis, they need to eviscerate the eye. So then only they can keep the shell and safeguard the other eye from getting sympathetic uveitis. In this context, we got the sample. This is not for diagnosis. This is for therapeutic. This is also therapeutic. In the intraocular contents, we saw tuberculosis, and now we are telling them, hey, please screen the boy for tuberculosis. You please look for lung tuberculosis and all these things. You are absolutely correct. But when the tubercle bacillus is only the RPE, the blood test will be negative, doctor. The PCR from the anterior chamber and the vitreous is going to be negative because the tubercle bacillus is sitting in the retinal pigment epithelium.
Thank you, sir. Thank you.
Thank you, sir. Thank you.
Thank you, madam.
We had actually Dr. Kritika's one case is pending. Are you able to share your screen, Dr. Kritika?
Yes,
she was not able to screen share then. Then that will be the final case of today.
Ma'am, is it visible, ma'am?
Yeah. So big. Yeah.
Ah, okay, ma'am. Good evening. I'm Dr. Karthik. First, I would like to thank my professors for giving me this opportunity. Today, I'm going to present an interesting case. A 65-year-old female came with complaints of abdominal pain for the past 3 months, and the patient was on treatment for bilateral lower limb DVT, and MRI and imaging showed a multiloculated, well-defined cystic lesion measuring 5 centimeter into 5 into 5 in upper pole of spleen, and the possibilities of splenic hydatid cyst and splenic mass was given, and the patient was taken for surgery, and total splenectomy was done, and we received a specimen of spleen measuring 17 into 14 into 5 centimeter. The external surface of the spleen was nodular, and cut surface showed a multinodular, predominantly solid gray-white mass, and there were also some cystic spaces. And this is the microscopy of the case, where we can see a neoplasm arranged predominantly in glandular pattern with central comedonecrosis, and the cells are round to polygonal with moderate amount of eosinophilic cytoplasm and to round to oval pleomorphic vesicular nuclei showing prominent nucleoli. And this is a picture showing lymphovascular invasion. And we have dissected 7 lymph nodes in the perihilar region of the spleen, of which 5 of them showed metastatic carcinomatous deposits. And with the spleen, we had a small portion of adherent pancreas measuring 2 into 2 centimeter, and the sections from the pancreas showed a neoplasm arranged in glandular pattern. And this picture shows the pancreas with the adjacent neoplasm. We went on to apply a panel of IHC markers. We did CK7, CK20, CK19, PAX8, WT1, synaptophysin, and MUC1. As the clinician, they were not sure about whether it is primary splenic or metastasis, and pancreas was dissected during our gross examination. We thought of metastasis, and to rule out colonic metastasis, we added CK20 and MUC1, and as the patient was female, we did WT1 and synaptophysin. And the markers, CK7 was diffuse positivity, and CK19 showed diffuse cytoplasmic and membranous positivity, and PAX8 focal nuclear positivity was seen, and WT1, synaptophysin, CK20, and MUC1 was negative. So with this, we gave the final diagnosis of infiltrating adenocarcinoma, moderately differentiated, arising from pancreas with infiltration of spleen. Spleen, most common type of malignancy in spleen is mainly lymphomas, and spleen is a rare site of metastasis regardless of primary malignant origin, of which choriocarcinoma is more common, followed by melanoma and followed by gastric carcinomas, whereas direct invasion to spleen, it is more common in pancreas, stomach, colon, and kidney, and mostly the patients will be asymptomatic, and they present with upper quadrant pain, shortness of breath, and early satiety. And these are the reasons why spleen is rare for metastasis, because it has constant blood flow, and the rhythmic sinusoidal contraction of the contractions prevent lodging of metastasis, and sharp angle of the splenic artery with the celiac axis, and lack of afferent lymphatics, and mainly the capsule itself acts as a protecting factor, and spleen is rich in immune surveillance cells, such as Kupffer cells and more of immunoglobulin and absonins and high concentration of angiostatin, statin. These prevent the process of metastasis. And in splenic metastasis in pancreas, it can be either contiguous spread or metastasis. And some studies show that contiguous spread of pancreatic adenocarcinoma to spleen has better prognosis than metastasis to spleen. These are my references. Thank you.
Thank you, Dr. Kritika. So the case showed a huge, the spleen was entirely involved by the tumor. So that was very characteristic, and it was a very rare presentation. So any comments on this? Okay, if we have, then we can close the session. So that was a host of beautiful cases presented from all organs. And so that comes to the end of our 30th City Pathology Meet. And we are going to have an academic feast in July, early July. And then maybe we meet with the next meet on in August, the third week of August. Thank you all. Thank you so much, ma'am. Thank you for your wonderful comments. And thank you all the presenters for your wonderful cases and your wonderful presentation. And thank you all the senior professors and all the pathologists who have attended the session. Thank you, ma'am.
Thank you, ma'am.
Thank you. We are finished on time. It's just 4. It's just thank you.
Thank you. Thank you, Vala.
Thank you, ma'am. Thank you. Wonderful set of cases, Enike. Thank you for the healthy discussion, and thank you for all your points. Thank you. Thank you.
Thank you so much to everyone and Vala.
Thank you, ma'am. Thank you so much. It was all your presence made it wonderful, ma'am. And every time we need a contribution from yours. Thank you, ma'am. Thank you.